The respiratory zone contains specialized microscopic structures optimized for diffusion. Unlike the conducting zone, these airways are thin-walled, highly vascularized, and lined with delicate epithelium. Damage here has immediate consequences for gas exchange efficiency. So these review questions really focus more on the alveolus as a functional unit. You should be able to explain how each cell type contributes to gas exchange and defense and how alterations, such as a surfactant deficiency or thickened membranes, could impair function. The respiratory zone begins where terminal bronchioles give rise to what's called respiratory bronchioles, as we can see here and here. This then leads to alveolar ducts, as seen here and here, and then alveolar sacs. And these alveolar sacs are kind of this whole combination of a bunch of individual alveoli. This gradual transition allows airflow to slow down dramatically, which maximizes the time for diffusion while also maintaining ventilation. Alveolar sacs contain clusters of alveoli, which total about 300 million in the adult lung. This enormous number creates a surface area roughly the size of a tennis court, which is insane. And this structural amplification is the single most important adaptation for efficient gas exchange. Gas exchange occurs by simple diffusion across the respiratory membrane. This membrane includes the alveolar epithelium, capillary endothelium, and their fused basement membranes. The thinner this barrier is, the more efficient diffusion becomes, which is a principle that explains why pulmonary fibrosis severely impairs oxygenation even when ventilation is normal. Our type 1 alveolar cells from the majority or form the majority of alveolar surface and are extremely thin. This facilitates diffusion. Type 2 alveolar cells are less common, they're less frequent. They're common, but they're less frequent, and they secrete surfactant and antimicrobial proteins, and they serve as progenitor cells for epithelial repair. Our alveolar macrophages patrol the alveolar surface. These are these purple structures here, and they provide immune defense where mucociliary clearance is absent. Alveoli are surrounded by dense capillary networks and elastic fibers. Alveolar pores connect adjacent alveoli, equalizing pressure and providing alternate airflow pathways if obstruction occurs. Macrophages continuously clear debris, with millions removed daily, underscoring the lung's constant exposure to environmental threats. I mentioned surfactant. So, what is it? Well, surface tension within the alveoli would cause collapse of these little sacs if unopposed. Surfactant reduces this tension by disrupting hydrogen bonding. It disrupts hydrogen bonding between water molecules that are lining the alveolus. By stabilizing these tiny alveoli, surfactant prevents atelectasis and reduces work of breathing. Loss of surfactant will dramatically increase respiratory effort. So, with that in mind, a developing fetus is unable to produce surfactant until the last 2 months prior to birth. So, explain why a baby born prematurely then might struggle to breathe. Well, premature infants lack sufficient surfactant, and that can lead to alveolar collapse and respiratory distress syndrome. Each breath requires an enormous effort to reopen a collapsed alveoli, and that quickly leads to hypoxia and fatigue. This physiology explains the life-saving role of antenatal steroids and exogenous surfactant therapy, which is what's actually given to these preemie infants to prevent this collapse from occurring. The fused basement membranes between alveolar and capillary cells minimize diffusion distance. Oxygen and carbon dioxide move passively down their concentration gradients. Any increase in thickness then of this membrane, this could be due to edema, fibrosis, inflammation, can disproportionately affect oxygen diffusion because oxygen has a lower solubility than carbon dioxide. Carbon dioxide is more soluble, therefore it moves easier across the membrane. So thinking about this in a pathologic sense, in emphysema, the walls of the alveoli are damaged and adjacent alveoli start to merge. We get these fewer but really large alveoli, as you can see here. Explain then how this can affect gas exchange. Well, in emphysema, our alveolar walls become destroyed. We have less total surface area for diffusion. And although the individual alveoli becomes larger, Gas exchange declines because the surface area on the actual alveoli decreases, and this elastic recoil becomes lost. Patients often will maintain normal oxygenation early on in this condition, but they'll struggle with elimination of CO2 and they'll struggle with expiratory airflow. We'll stop here. When we come back, we'll look at the role of our nervous system in respiration.